Another item is maintenance therapy. And of course, in non-small cell lung cancer, first line, particularly for adenocarcinomas, we give pemetrexed. That is well established. Another item has been, should a PD-1 inhibitor be given after chemotherapy? Now, you already mentioned, Naiyer, a little bit this issue that pembro given first, at least if you then wait until progression, chemotherapy is not an effective rescue agent. Whereas if you, it can be an effective, but the opposite of starting with chemo is inferior. But in those cases, you're actually waiting for progression to occur, whereas in the classic maintenance context, you would not do that, and you would simply go from one modality to the next. And so for PD-1 or PD-L1 inhibitors, what experience do we have of starting with chemo and then going to maintenance therapy?
I don't think we have.
And do you see it as a valid approach?
Yeah. I don't think we, we have any experience, doing that. To give chemotherapy first and then transition to PD-1 as a maintenance. I think those questions are being addressed. Certainly, for KEYNOTE-21G, patients received chemotherapy for 4 cycles and then they continued pembro as maintenance, but there wasn't the option to continue pemetrexed as maintenance as well, which most of the patients actually did. I tend not to do that. I think that if I'm doing that regimen, I will give them the chemotherapy and then just continue the pembrolizumab, because I think that you want the T cells and you want the immune system to be activated, and if you're giving them steroid pre-medications with every pemetrexed and you're suppressing their marrow, then perhaps there could be some negative effects. So when I think of maintenance therapy, I think of it as pembro alone rather than pembro and pemetrexed.
Can I make a comment, Everett? So these days we see a lot of combination therapies out in clinical trials. And you are asking the question of maintenance immunotherapy after chemotherapy for patients, I guess, who respond to chemo. Now, I would like to ask the panelists if they agree with me that there is a huge lack of scientific knowledge around what does it mean for the immune system when you give chemotherapy. I mean, the rationale for giving immunotherapy after chemotherapy should be based on some scientific knowledge about what does the chemotherapy do for the immune system. And as far as I know, there is very little knowledge about the biology behind it on this stage. I hope that current clinical trials will include the translational research who give that knowledge, so we can have a more rational combinations and sequencing of therapies in the future. Will you agree with that?
I agree with you, Fred, in that we have only scratched the surface in terms of our knowledge about what factors drive responsiveness to immunotherapy, how does radiation therapy play into it, how does chemotherapy play into it. Our bone marrow transplant colleagues have long time used chemotherapy to address some of the immune issues, for example, to suppress MDS, to clear the marrow and so forth, MDSCs. So I think at this point, proceeding in a stepwise manner is important. We don't want to assume that what's good with chemo is good with immunotherapy. These concepts have to be studied in a well-designed, randomized clinical trial and then be adapted to practice.
In the Alliance, we have a trial that may come a little bit close to this, where before the pembro data were out, we randomized patients to either 4 cycles of chemo followed by a PD-1 inhibitor, and not waiting for progression, or the other way around, starting with pembro, but then stopping after 4 cycles to give, or 3 months, to give 4 cycles of chemo and then going back on the pembro unless there was initially progression. So it's a little bit complicated on that arm. But the intent was to address the sequencing issue in that trial. What really was needed is a third arm where the two are given together. And unfortunately, that was not included. So that ultimate comparison will not be there.